Thank you for joining our first webinar called Engaging Clients, Building Relationships, and Making Effective Referrals. A little background information. In May of 2013, a survey was conducted of past participants of our two-day Journey to Promote Mental Health workshop to determine what other training needs they had. 43% of English respondents indicated that clients refuse mental health referrals, and 21% indicated that they do not know where to refer their clients. Also, when given the choice of over 20 potential webinar topics, navigating the health system and successful referrals was in the top 5 choices. We are pleased to have as presenters today psychiatrist Dr. Fung, a staff psychiatrist and clinical director of the Asian Initiative in Mental Health Program at Toronto Western Hospital, University Health Network. He's also an associate professor with Equity, Gender, and Population Division at the Department of Psychiatry, University of Toronto. And we also have Alison Hunt, director from Access One, Toronto's centralized application center for mental health case management and assertive community treatment team. This webinar is funded by Citizenship and Immigration Canada. Okay, well, thank you. And I am pleased to present Dr. Fung.
Okay, hi, good afternoon, everyone. I hope that you can hear me okay. And as you've heard then, today's seminar is devoted to the title, Engaging Clients, Building Relationships, and Making Successful Referrals. And this is going to be divided into 2 parts. I'm going to be speaking on the first part, and I will switch over to Alison on the second part. Okay, so the first part is about engaging people who don't want to get help. So I think that this is actually quite a common experience that we find that, first of all, even when we identify that there may be a need for either the person, in other words, your client, and or your client has identified a family member or friend who needs help, they may have some resistance towards getting help. They don't want to get help for a multitude of reasons. And sometimes what we feel like is like this picture here, where you are kind of trying to both push and pull, but you're not just getting the result you want. It's almost like you can lead a horse to the water, or water to the horse, both, but at the end, you can't make the action you would like to happen, that is the drinking occur. So you can see the little boys there tugging and doing that. And in fact, when I do public health talks, it's almost at the end of every talk that I get at least 1 or 2 questions that a mother or a sister or brother would say that they have a loved one that they cannot convince to get help. So we're going to dive into this and together and see what we can understand about it and what we can do about it. Because of course, even if we know all the access of services in the world, if the client is like the donkey here who is refusing to budge, then nothing's going to happen. So we want to start from kind of that kind of mindset. How are we going to able to facilitate people to really get help? And in fact, because of this phenomenon, I've also encountered a number of situations where, if you look at this picture, what you see here is kind of a cake, but not like an ordinary cake, a cake laced with pills. And unfortunately, I have come across a number of examples where the families and the healthcare system, I guess more so the families, are so frustrated that they've ended up actually dosing or helping the patients get medications, even like in spite of the actual patients not knowing they're receiving it. So I've had families who talk about getting medication from somewhere, dissolving into soup or disguising it as food. And obviously we can think of all kinds of problems regarding that. And a related phenomenon then, same with making referrals. I've had people who've been referred to see me or gone to some other services, but the client actually didn't know until they get there. It was actually seeing a mental health service or a psychiatrist. In other words, the client and patients, because they have refused to get help, sometimes family members or people around them get so frustrated they end up using deception as a means of getting them to get help. Now, obviously, there are a lot of ethical problems with this approach, and there's also a lot of, from a health standpoint, medical issues that can be dangerous. And if we think about it, obviously, it violates everything to do with client-centered, person-centered care. And think about also then the potential destruction of the relationship, because oftentimes you can't hide something like this for a long time, especially if you are deceiving someone to get a referral. When the client or patient finds out, then the fallout can be catastrophic. So for all kinds of ethical, medical, practical, and also the damaging to the relationship from all these kinds of perspectives, what we don't want is this kind of approach where we use deception as a means of getting someone to get referred. So then maybe we can begin the session by some reflective questions. Now, knowing that this is a webinar, I know that I was told that the interactivity is kind of cut down a little bit, but still, I want to first begin this by some reflective questions. So I'm going to ask you two questions. What I would ask you to do is actually to take a pen and paper and jot down your response to this. So the first question is, why do you think that people don't want to get help? Why don't people want to get help? So can you just take a piece of paper, or you can type it in your computer, or you can write in your iPhone or something like that. Top 3 reasons why you think people don't get help. And the second question is, what are some of the emotions that you yourself feel when you encounter the situation? Again, write down the top 3 emotions that you have within yourself when you encounter a situation like this, when you hear a situation like this. So I'm going to deliberately pause for just like 15, 30 seconds so that you have a chance to just think about this and write down top 3 reasons why people don't want to get help and top 3 emotions that you feel when you encounter this situation. So I'm going to time you. So this is not the time to run to the washroom or check your email, but to write down your answers. Okay, so I hope that you have had a chance to reflect on these questions, because as we continue this presentation, we'll see if your answers match up with what I think you might have answered, or what I've felt myself, or what I've thought about before. So what are some of the possible barriers to get help? I think that there's a cluster of reasoning where we may think that the person is actually resistant to getting help, they are denying that they need help, or they're just not wanting to get better, or they're too sick to want to get help. The person just have a mental health issue, they're too crazy, they're too psychotic, they're too dumb, too stupid to get help. Maybe we have all kinds of thoughts possibly like that. So that's one group of response. Another could be maybe they're just too afraid to get help. Another may be because they just don't know better, they lack the knowledge, they don't understand. Another group of reasoning may be because of stigma and shame, because we all don't want to talk about mental illness. That's probably the reason why. Now, I wonder if you look at your responses, whether it falls into those categories. And if it doesn't, I'd like to also hear from you, maybe through the Q&A, what other reasons people might have for not wanting to get help. And now I'm going to dive into each one a little bit to discuss them further. The first category, or resistance, denial, not wanting to get better. And you can see a picture here of someone plugging their ears. Now the term resistance actually comes probably from even just psychoanalytic tradition of psychotherapy. By that, we mean that in the psychological history of trying to get people to get help, we often encounter people who don't respond to our intervention as we hoped. And then we theorize that there's a resistance going on. And sometimes it's an active denial, people denying that they have a problem. Sometimes we even say that they actually don't want to get better. They are wanting to suffer. And other times, we might feel that the person is so mentally ill that they just simply are too sick to want to get help, or too stupid, or too ignorant, or the list goes on. Now, this certainly, so this is kind of one kind of way to understand the situation. And in some of the cases, maybe it's actually even happening. Maybe it's possible that person is denying their mental illness, or maybe the person does not want to get better. But I would say that there's a certain kind of trickiness to use this kind of reasoning to approach the situation. Well, first of all, because this kind of reasoning means that you're putting the problem on the person. And when you put the person on, this is that person's problem, then sometimes there's nothing you can do about it. So there's a sense of, first of all, this may not be the most useful approach necessarily in terms of getting the situation, resolving the situation, getting the situation unstuck, right? So even if for a moment we believe this is really happening, for sure the person is denying, knowing that it's okay, but if this is our conceptualization, sometimes it just paralyzes the whole process because that's it. The person is denying. There's nothing more we can do. We have to throw in the towel, as it were. So I think that's kind of one of the problems with using this kind of conception to understand the problem. So while this could be happening through various psychological reasons, stopping at this point is probably not the most helpful thing. We definitely have to move beyond this reasoning, even if we really believe this is the case, to get further. And finally, I qualify that as even if this was happening. The reason I said it is because as we go on then, we'll find that there are potentially many, many other reasons that would cause us to believe, it's just a person denying, but maybe there's a whole host of other reasons that we should first need to think about and to try to address. Now, the second category are the emotional factors. That is, sometimes we believe that the person is too afraid or too scared or too sad to respond, to want to get help. So I think that starting with this approach, it's a little bit more helpful because we're now attempting to really understand from the person's point of view, from the client's point of view, what they are feeling. Because often, of course, we do things often motivated by our feelings. Like right now, you're listening to me, hopefully feeling energized, excited, curious, right? If you are feeling tired, bored, and you're letting your screensaver come on, that's not very conducive to learning. So emotions, obviously, we call emotion motivational, right? So emotions often seem to give us motivation. And a second reason why this is important is right now with our cognitive way of understanding how people work is that our emotions and our thoughts are quite tied together. If people are afraid, then behind that, they are having certain thoughts or conceptions of what getting help could be like, what it means to get help. And so if we start with understanding how people feel and then what people think that's tied in with those emotions, this is going to help us get a deeper understanding about why the person is not getting help. So understanding how the person is feeling, probing that, exploring that, well, how do they feel about getting help? To pay attention to their feelings and then inquiring why they have those emotions. What is their story? What are their thinking behind it? Helps us perhaps to start to unravel the puzzle a little bit more. Now, the next slide is explanatory mode of problems and illness. Now, this actual phrasing, explanatory model of problems and illness, is a terminology that we use in cultural psychiatry a lot. It also comes actually from medical anthropology. That is, the way we are structuring our current way of getting help, whether it is psychological, psychiatric help, other kind of mental health support services, or even rehabilitation programs, social services, or physical health in general, it's based on, of course, our current Western mainstream way of structuring things. And we do so for a good reason. However, every person and every culture have different ways of addressing problems, illness, and issues. So this is to remind us that if we're talking about serving immigrants, refugees, people from diverse cultures, every culture comes with their own rich traditions of how to understand health, mental health problems, family issues, etc. So in other words, sometimes it's not that they are too afraid to get help or they just want to suffer. It's actually that they have an alternative way of thinking. So without probing and understanding where they come from, then essentially we have a clash of your values versus their values, your way of doing things versus their way of doing things. Oftentimes, clients and patients, they don't feel that they have a voice to voice this, what they're really thinking about their issue and situation. So you may not find out that what they have actually tried to do about the problem and how they go about getting help. So asking those questions about, well, what do you think is going on? What do you think is helpful? So getting that from the client and patient is very helpful to getting you a picture of where they're coming from and how you can jointly work towards a solution. Next is stigma and shame. Of course, mental health issues and support services come with a certain stigma in this society, and the feeling of stigma and shame can become a barrier. This is, of course, the case in the mainstream society, and it can also be even added in certain cultural groups in particular, because in certain cultural groups there are even more stigma about mental health issues. And in more collectivistic cultures, sometimes the shame and stigma is magnified, because in a collectivistic culture, if you have a problem, it also looks bad for the family. So the shame can be augmented and shared by the whole family. And in such case, you may find that not only the client is resistant, but the family may also be similarly resisting to get help or not wanting to get help. So this is another factor to consider. How do we address the issue of stigma and shame? And actually, talking about stigma and shame leads directly to the next issue that I want to talk about, which is contextual factors. Because stigma and shame doesn't only reside in the person. Shame and stigma occurs because it's our societal way of interfacing with certain issues, how we treat certain issues, certain labels. So in fact, in my earlier slide, I didn't even list this because I think most people don't think of it, but that is, we actually need to think about the context, the whole situation surrounding the person. Because not only it depends on the person whether they want to get help or not, but it's also what it means when they do get help, what it means for the family, what it means for the community, or how the society view it. So all the surrounding contextual factors are important. And this includes even situational factors like money, transportation to get to the place they need to go. What does it mean? Is the workplace going to be okay with a person taking time off to get help? All those contextual factors are real life barriers that sometimes we don't consider. And so I hope that this next picture will be a familiar reminder to you all through the level 1, level 2 training through the Hong Fook, which is a holistic way of looking at the issues and problems. So we can start with there's the mental illness, there's the body, but there's also the mind, the spirit, how family, we talked about the family influence on the person getting help, societal, how they treat it, the environment. So all of this has an impact on whether the person gets help. So this is to expand our reasoning beyond, oh, the person's not getting help. The answer could be, have we consider everything around the person. Do we have a facilitating environment for the person to get help, or is actually the environment is also pushing against the person wanting to get help? Now, how do we address this? Now, I think one of the first steps is this, which is why I kind of began today's talk with asking you to kind of reflect on those questions. Having a time out to kind of reflect on the overall situation, having some kind of making room and acceptance for people not immediately doing what we're saying. Even that picture of a donkey, sometimes we might kind of think the person is so stubborn like a donkey, right? We are almost making a caricature or pathologizing someone. Rather, if we have a more acceptance stance to the whole situation, and if we can have a more calm, more peaceful approach, I think that's going to help to the whole situation. Because if we are working with a standpoint of frustration, if we are kind of problematizing the problem as a person, we can get into this tug of war, this pushing and pulling thing that we struggle with. So the first is to kind of let go of that struggle, to kind of center ourselves, because that can probably be most helpful to the entire situation. The second is on building a relationship, which is one of the titles of today's talk, and for a very good reason, because I think that the entire process, one of the key aspects is building that kind of trusting relationship. So this includes the basic interviewing skills that you've learned from the basic level and advanced level training, active listening, empathy. So we have that Chinese character of listening with your eyes, ears, and heart, and undivided attention. So that kind of active listening and expressing empathy is kind of key, of course, to building a relationship. Now, even a while back, a couple months ago, I was at a conference in psychotherapy that had like the world experts on psychotherapy, and one presenter was reviewing all the literature. And in fact, what is shown that one of the things that distinguish, there are some people who are actually more effective than others. But those people who are the most effective are actually the counselors or the advisors or the therapists who actually actively elicit feedback from the client. That is to kind of say, I'm recommending you to do this. How do you feel about this? So actually asking for feedback is one of the proven things that distinguish a skill of having a good collaborative relationship and outcome versus another who would be, pretty good, but not expert, right? So when they look at it, sometimes the expert therapist, expert counselor, or why is that expert counselor getting so much better results? It's not because of the extra tons of hours of Hong Fook training they get, but it's their ability to have an open stance of eliciting feedback from the client and then working with their client on what they want and have that negotiation. And finally, obtain supervision and consultation. When you're stuck, it's rather than either giving up or just putting it as a hopeless case, obtaining appropriate supervision and consultation can be a key. Addressing concerns is step number 3. So with all this talk about client center then, and elicitation of the client's point of view, is actually addressing some of the concerns that the client brings up. So sometimes we see that there's a pressing mental health issue, or there's a family crisis, that the person really needs family therapy or couple therapy. However, this is what we identify as the top of the priority list. Again, if we're able to be open to what the client's top priority list is, and we're able to address some of those concerns, sometimes you find that the person would then be much more cooperative with working on a treatment plan or management plan or referral plan together, because you have addressed their most pressing need. So working, again, at addressing what their top concern is and not ignore it. And another concept I want to bring in are the stages of change. Now, people who have experience in especially the addiction field, would have a lot of familiarity with this concept. If we think about a model, this is a trans-theoretical model that's been proposed as look at how people change their behavior. As you know, we have a certain way of behaving. We have a certain way of dealing with issues and problems. We have a certain kind of habits, lifestyles. Because we were all not born yesterday, we have our own history, our own experience. Now, if we take this stage of change, what this says is there's a pre-contemplation phase. In other words, there are people who have never thought about changing, right? Because they are going along their merry way. This is their way of handling things. Contemplation is the next phase where people are thinking about maybe they need to change, but they see some pros, some cons. It's not their usual way of doing things, but they're starting to contemplate should that change. Preparation is the next phase when they are deciding they need to change, but since this is a new thing, they're just kind of getting information, maybe changing a little bit, making initial attempts. And then the action phase is they're actually making a change. And the maintenance is whether the person is going to follow through and continue the action, or they're going to go back to their old ways. So if we look at this cycle of stages of change, what it is proposing is that in order to get people to change from their usual way of handling things to a new way, sometimes it depends on where people are at. So this is what we mean sometimes by saying, oh, we're not ready for a change. So similarly, if we think about people who have issues, who have problems, sometimes they are not in the place to accept that they have a problem, accept that there's an issue here with the way they're handling things, or accepting that they need extra help. So they could be even in the pre-contemplation phase. And if this is the phase where you are thinking the next step must be action, as you can see, there's the discordance. This is why I start off with those early examples, right? People who are not ready to change, and then we are saying, no, we must take action. So therefore, we are either forcing medications, or we are tricking them to an appointment, or we're deceiving them because we're trying to have the person skip to an action phase when they're not ready. So if we look at where the person is at, we can ask ourselves, what is the best way to move the person forward, one step at a time, with the ultimate goal for them to agree to take action. So in the early phases, it can be simply heightening their awareness of their need to change. So helping the person reflect. So that's why today I began by having you reflect on how you generally feel when you have clients who are stuck. Oftentimes the place to start for any change or any behavior is through reflection before we are able to identify within ourselves what is working well, what is not working well, and what can we change and improve our lives. So we can go with that, look at where the person is at. What does the person need? Does the person need more information? Does the person need, if the person sees barriers, does the person need help to address those barriers before we are ready with the planned action of getting the person to be referred? And now, number 5, the bigger picture. So this is in correspondence to my earlier discussion about looking at contextual issue, which is always keeping in mind the bigger picture. So sometimes the way to get help for the person may be mobilizing the family who can encourage and support the person to get help. Sometimes the person is at odds with the family. Sometimes the person has a trusted friend, a trusted pastor, a trusted spiritual advisor that the person will listen to and would consult. And sometimes it is this bigger picture of getting other people involved may be the best person and maybe the best approach to mobilize the person's resources to get help. So, and this is also then addressing the support network and support system in the family, the community that can help the person get help. Again, at the same time, we may also be looking at barriers that we need to help. Sometimes the person wants to get help, but it's the family that's not giving permission, or the person thinks that the person needs to get a permission from a spiritual advisor before moving forward. Sometimes it's also practical issues like, unless my mother-in-law is going to help with my child care, I'm not going to be able to come or go to any appointments. So sometimes it's solving those kinds of issues by looking at the bigger picture before we're able to resolve this situation. And then the next is there are some red flags that will cause us to promptly intervene, because up to this point, we're saying that the most important thing is state approach, understanding our urgent emergent issue where it's true that we may need to so situation dependent. If you feel that the person harm themselves or other people, if there's a child protection issue here, this is just a reminder that in that case, child protection services needs to be called. And in the first case, if it's an emergency, if the person obviously can die tonight, you're going to need to do something at that point to protect the person or others around them. And in an emergent setting, this may mean getting local law reinforcement, getting the police in if it's an emergency. And in other cases, it may be providing necessary information for the family or yourself acting on the person's behalf to get legal assistance. In Ontario, the Mental Health Act governs that. There's something that's called a Form 2 that's issued by the Justice of the Peace precisely for this purpose. That is, when a person is in a dire situation that is at risk of harming themselves and others, and this is like an urgent situation that cannot wait for all those things that I've talked about before to occur, that the Justice of the Peace can issue a Form 2 in Ontario, and then that can mobilize the local law reinforcement to bring the person to a place of help where the person would get further assessment and consultation and intervention as necessary. So hopefully that gives us an idea then about how to a stepwise approach to tackle the quite common actually phenomena of people having reservations about getting help. And now the next part as a bridge to Alison's excellent, wonderful talk that you're about to hear on all the wonderful resources that we have is just some basic issues about making an effective referral. So this part is, again, now we have moved to the client to a place where the person is thinking about, being referred to services. What are some of the key things I think would be helpful to keep in mind to ensure that the referral is successful? So before the actual referral appointment or consultation or intake services occur, I think there are three key points to keep in mind. Well, first is the process of working with the client collaboratively to identify the need and the most appropriate consultants and services. And sometimes by working with the client, you may have the favorite place to refer to, but the client may have another idea. The client might have heard from a friend that this other place is good. The client may have this other need that they've identified that you may need to think about other services as well. So through this working together to iron out exactly what services are available, it's going to help you make the most appropriate referral and then offer choice. Now, going through this process, sometimes identifying one or two choices and offer that choice to clients helps the clients feel very empowered because they have a choice that they can make. It's not like, if you don't want to see this person, then you have no other, then it's hopeless, right? So don't refer everyone to me, for example, right? So always offer the patient choices because you want to empower the person with as much choices as possible. People are more likely going to go to something that they have had some say in choosing. The second is to clarify and implement the correct referral procedures. So if the Hong Fook referral form has 12 pages, make sure you fill in those 12 pages because incorrect information, incomplete information can lead to a lot of problems. And the third point is before the services take place, it would be good to go over with the client these 3 points: who or what to bring. At different services, they may want to interview a support person or family member or friends or spouse or children. So who to bring and what to bring. Like if they see a doctor, for example, for any kind of consultations in general, they will want them to bring all the medications they're taking, for example, right? And if the person has all kinds of ODSP and other kinds of forms, maybe they need to bring them with the first appointment. They have lots of things they're unclear about. They need to bring that with them. So going over who and what to bring, and then what to expect, because this is new for many newcomers. They may have no idea what a psychiatrist would do, what a psychologist would do, what a social worker does. Social work doesn't even exist in many countries. So going over what to expect would be fairly important. For them, sometimes their experience with governmental agencies can be even traumatic, for example, for refugees. So they may even be scared, but knowing what to expect helps. Is it going to be a 15-minute appointment? Is it going to be a 1-hour appointment? Are they going to have a lot of questions? So all of that, going over that is helpful. And then finally, always ask this question: are there any barriers for you to follow through? And ask them how certain they're going to follow through. If they say that I'm probably going to go, but sometimes I'll forget things. I'll probably go unless my child gets sick again, or I'll probably go unless I have a fight with my mother-in-law again, right? So sometimes or unless I don't have a token that day, or my husband gets, is drunk again. So unless you ask for any barriers, you're not going to find out these things. So always ask this question and ensure that this is going to be okay. Now, during the consultation and intake services, your role, depending on your agency's mandate, but what are some of the things that can be helpful? Either you can do it in person, or you can arrange a colleague, or you can arrange other people to be able to do this. Includes things like a reminder for people to go to appointments, or transportation, or interpretation if there's a language issue. So think about how you can facilitate so that the initial assessment interviews can be useful and not kind of a waste of time for both parties concerned, which can be demoralizing for the client and can be frustrating for the other end. How do you provide support? And this can be emotional support. Some clients are really, really scared. And how do we think about either, again, arranging someone so that the person can go with the person for emotional support, or you yourself can go. And then thirdly is informational support. Again, providing information. Sometimes if you know that the client's not going to be able to give a good history, again, think ahead. If a client has family that can explain the situation well, or if you can fax some information ahead, sometimes all of this is very helpful for consultation to take place. And now my last slide is post-consultation, because of course we make referrals not to pass the buck. We make consultations doesn't mean that it's now someone else's problems. It's most important to follow up with the client about what that experience is like, because oftentimes the person may or may not have a fabulous experience. So understanding how it went from the client's point of view is important, and then following up with the consultant or the services. The other consultant services, they may have very busy stuff. Clients can still get lost after initial intake for all kinds of good reasons. So it's also, and sometimes client didn't understand what the next step should be. Maybe the client's waiting for the services and consultant to take the next step, while the consultant has already explained and is waiting for another step to occur. So sometimes following up with the consultant or services about what the next step is important. And then with all the information, of course, is facilitating the next steps. And sometimes the person may need other kind of help. And with this, I would then, what are the next steps and just what are the resources? I think this is the most appropriate time to transition then to our next expert speaker, Alison, who's going to take us through some of the resources that's available to us.
Okay, hello everyone, and thanks for being here, and thank you very much Dr. Fung, for such a great presentation. So we're going to change gears a little bit now, and we're going to talk about resources and access to resources. I work in the Toronto area, and I am the director of Access One and the Coordinated Access to Supportive Housing. So I'm going to be focused a little bit on Toronto, but I do recognize that a number of our attendees here are from other parts of the province, in other cities, and so I will try to touch on what might also be available in your local communities. So what I thought I'd do is I'd start by talking about who we are, what we do, how to access mental health support, what the mental health system was like before and how it's changed and what it's like now, and then also talking about access to mental health housing as well, because there's been some recent changes in that area. So as I said, I work for Access One. Access One is a coordinated access hub within the City of Toronto, and our sister organization is called Streamlined Access, which is in the York region. So with these particular hubs, what it allows us to do is we have a whole bunch of different mental health service providers who are linked into our network. And so we provide a coordinated access point for a whole bunch of different service providers. And the same thing goes on in York region. This is actually an initiative from the LHINs, the Local Health Integration Networks, and they are quite interested in this idea of coordinated access. And so coordinated access is going to start becoming more of a trend in other areas within the province as well. So in your local communities, you might start hearing about coordinated access in your communities as well. And so this, I'm going to give you the concept of the centralized or coordinated access now, so that when it comes to your communities, you'll have a better sense of what that means for you. So the slide that you're seeing on the screen right now just talks a little bit about the two organizations that are the lead organizations for Access One and Streamlined Access. And so you can see the variety of services that those two organizations have. So York Support Services Network as well as Toronto North Support Services. They have a whole range of different services under the umbrella of those two organizations. So with the coordinated access point, what we are coordinating services to is what we call intensive case management or assertive community treatment teams. So these are individualized mental health support services that are community-based and go out into the community to work with individuals with mental health issues. And so although I'm going to be talking mostly about these two types of services, I will touch on a couple of other services that you might be interested in for your clientele as well. The reason I'm talking mostly about these two services is that these two services are available in most local communities within Ontario. So wherever you are, you probably can find supports that are either intensive case management or assertive community treatment. So intensive case management is we work with individuals who have a mental health diagnosis and who need one-to-one support. We deal with a whole bunch of different support type issues. So we can help individuals to go to appointments, to maintain their medication regime, to maintain their other support services. We can help them with finding jobs, trying to get on ODSP or OW, or trying to link with other supports that they need, depending on what their life circumstances are. So it's a whole range of different services that a case manager could help an individual to access. It's usually at least weekly support, and the case managers are able to travel in the community, so they would go to individuals' homes. Assertive community treatment teams are a little bit more intense, highly intense, and so this is for individuals who have a more complex clinical presentation. So often it's people who've been in and out of hospital frequently, lots of hospital days, and needing lots of support in order to maintain their treatment regime. And so with assertive community treatment teams, it's a team of individual staff. who work with that individual. So in terms of case management, it's usually a one-to-one relationship, the case manager and the client. But with assertive community treatment, it could be a whole team of individual staff who work with a particular person. So there could be a psychiatrist on board, a nurse, OT, occupational therapist, a peer support worker, vocational workers, or rec therapists and addiction counselors. So depending on an individual's needs, that team would be surrounding that person and helping them to stay well in the community. So these are the two types of services that are generally available within most local communities. Now, before the idea of coordinated access, what you found was as you being frontline in terms of coming across individuals who might need help, you didn't know where to turn, and you would need to call a whole bunch of different organizations within your local communities to try to figure out where to refer someone to. And so sometimes it would be 15 different calls to try to figure out where to refer someone to and then make that referral. Sometimes the calls wouldn't be returned. Sometimes you'd get the runaround and be told to go to various different organizations. And so it could be really confusing. And so when we look back at Dr. Fung's questions about why don't people get help, some of it could be this, not knowing how to navigate the system and not knowing where to call. Not having that information, and so people just give up really easily and don't get the service that they need. And so the idea of the coordinated access was to take this picture that you see on the screen and turn it into this. And so this is what we do. We provide coordinated access. So we have one common application form that gives access to a whole variety of different service providers. We have a specific set of eligibility, and from the Access Hub, the coordinated point, we are able to determine if someone is eligible for those services, and then we maintain a wait list. We also are able to provide individuals with help to get to other complementary services while they're waiting on the wait list for the service that they've been deemed eligible for. And so usually it's one call. And then we at our office will help individuals to then navigate the system and figure out what it is that they need services for. So we provide information. We provide information on a variety of other services out there in the community, not just for intensive case management and assertive community treatment, but also for all those other complementary services. We also will help do warm transfers to get them to the right door if they're not eligible for our services. We have access to short-term support. So even though there's a wait list for our services, if an individual is really, if their situation is really critical and they need more urgent support, we can access short-term supports for that person while they're still waiting on the wait list for the services they've applied for. So sometimes that helps to mitigate some crisis situations. Maybe if a person has just gotten notice to be evicted, we might be able to get a short-term case manager in there to help prevent that eviction, which then, of course, prevents a lot of other crises down the line. We also have access to peer support. So we have peer support workers within our team who are able to provide check-ins and information and some informal counseling for individuals who are waiting on our wait list. So as I talked about, it's a single point of access. We accept applications by phone, fax, email, or walk-in. And then what we do is we determine eligibility. Within a couple of weeks, we would be engaging with the individual and anybody who is in their life who wants to participate in the intake assessment, and we would be determining eligibility within a few weeks. What this means for individuals is that it's an easier, less fragmented way of getting services. There's timely information. At our hub, we keep information about which providers are able to have turnaround and turnover. So we know which organizations within our system have openings at any one particular time. So we have up-to-the-date information that we can provide. We also can, as I said, be able to link them to other services that they might also need in addition to the case management and assertive community treatment team. On the screen now, there's a couple of quotes that I won't take too long to look over, but these are quotes for individual service users who have accessed our Access Hub and what they have found or experienced from our services. So you could see that some people really appreciated the time we took to spend with them, to do an assessment, to figure out what their needs are. So when Dr. Fung talked about some of the things that you can do to help engage individuals and help them to be ready for a service, a lot of it is spending time with individuals, getting to listen to what it is that their particular situation, what it is that they specifically need support with and help with. So a lot of individuals who come to us, they come to us not necessarily knowing if they want case management or assertive community treatment, but knowing that they need help with a particular issue. And usually we can take that issue and talk to them about how we can help them with this issue and a lot of other issues, and so that it helps them to become more motivated to work with us, because they're able to see that we are listening to them and we do want to provide them with the support that they need as well, not just what we think they need or what their parents think they need or what their doctor thinks they need. We do try to really engage them on their level about what their goals are. So what we've done, this coordinated access point, it came together because a whole bunch of different organizations voluntarily came together and wanted to talk about this idea of coordinated access. So now that we have a coordinated hub, we are able to keep a lot of statistics on who's getting service in the system, who's not getting service in the system. So this benefits the system, because then we're able to do some systemic advocacy. We've also been able to do a bunch of surveys and get a lot of consumer perspective on what it is that they need, so that we're not just providing something that we think people with mental health issues need, but what people are actually telling us they need. One of the big things that has happened recently is that we have integrated with the coordinated access to supportive housing, and that was a big step. So Access One provided coordinated access to individual mental health support services, so case management and ACT. CASH is a similar thing. It provides coordinated access to supportive housing, and there's a variety of different levels of housing within that umbrella. And so they do coordinated access for supportive housing, and now we have integrated. So we're about to launch a new joint application form so that individuals can apply for housing and individual mental health support services within the same application form and within the same assessment process. So they won't have to go through multiple intake assessments. It'll be one intake assessment where they will be found to be eligible for both services. So again, it's creating a even more streamlined access to those types of services for individuals. So here's some information on CASH. It's we have low, medium, and high support housing. We have individual units as well as congregate and shared living. This central wait list allows individuals to be considered for a whole bunch of different types of housing options. And so, again, it helps to remove barriers by pointing out to individuals what they're actually eligible for and providing them with all the information and the choice that they want. So, again, choice is a really big issue, and if people are able to know what their options are and to choose their options, they're more likely to engage with the service and actually follow through. So here we've talked about the process is essentially that we have an application that's submitted to our office, and we would do an intake assessment, either for housing or for case management or ACT. We would do an assessment to determine their eligibility. And so we're looking for if, in terms of housing, if they meet the criteria for their financial income, if they meet that threshold. We're also looking for if they have a mental health issue and if they need support. So it's a fairly low threshold in terms of what it is that we're looking for. for individuals, and then what we would do is we would put them on the wait list and provide the peer support ongoing while they're on the wait list. So the partners for streamlined access are these listed on the screen now. The partners for Access One in Toronto are listed here. And so you can see that all of the assertive community treatment teams and all of the intensive case management teams within Toronto are part of this Access Hub. Now, that's not to say that some individuals could apply directly to these actual service providers, but it has to be a specific reason why they would apply directly. So most of these providers, you apply to Access One to gain access to these service providers. But there are some communities, specifically cultural communities, who may never find the Access One door if we were expecting them to just call up Access One. And so some of our providers do provide services specifically for ethnocultural communities, and so they would be able to accept referrals directly to them as well. So an example is Fook Mental Health Association or Cross Boundaries, who serve very specific communities, and so they still maintain direct access to them as well as coming through the Access Hub. In terms of our providers for the housing network, you can see that there's a whole bunch of other providers. So within the Toronto area, Access One and Cash, there's more than 41 service providers that you can get access to by making an application through us. And so that gives your clients quite a bit of choice. So the next few slides are information about actual phone numbers of where you might want to call if you were looking to get access to information. One of the things, though, that I should talk about is that if you're unsure where to refer to, places like these coordinated access hubs are a really good place to start because the staff of these organizations have a lot of information, not just about, say, case management or housing or assertive community treatment, but they also have a lot of other information about other resources that could be helpful. So they often know a lot about employment programs for people with mental health issues, or drop-in day programs, or recreation therapy programs. So if you're unsure of where to call, probably the best thing to do would be to call a coordinated access hub like Access One, because we're always open to you calling and just getting information or presenting a situation that you have, a client situation that you have, that we could maybe provide you with some feedback about what you could do. One of the things that in your local communities that you might want to think about if you don't have a coordinated access point is looking for the local mental health organizations, because they're a good place to start in terms of asking questions. The other thing that might be really helpful is some of the provincial lines that we have available. So we have drug and alcohol helplines and mental health helplines that are province-wide. 211 Ontario or Connex Ontario are really good resources to learn about your local communities. The Canadian Mental Health Association is also a really good place to start. They have an Ontario branch, and they have a variety of different branches throughout all of the local communities, and could be able to help you to figure out where to go within your local community for mental health support. Some of the crisis lines are also good. I've listed some of the crisis lines in the Toronto area. They're also good for some of those situations where, as Dr. Fung talked about, that there's some red flags going up and that you might need to get services quicker rather than later. One of the things that is also something to think about in your local areas are the community care access centers, so the CCACs. They often have access to occupational therapists and social workers who can do assessments in the home again for individuals and to see, to do an assessment to figure out what it is that your client might need. The other thing is if you have the family health care team or just even access to your GPs, regular GPs, can be a good first step in trying to gain access to support. In in terms of barriers, Dr. Fung talked about some barriers, and of course one of the big barriers is information, and knowing how much information that you can access to give to your client. And so sometimes that can be really hard. You don't know where to turn yourself. And so again, the trying to connect with your local CMHA or your local access hub would be very helpful. Now, in terms of access hubs, as I had said, that this is something that the LHINs are quite interested in, and so they will be growing, and you will be starting to see them in your local communities. I know that the Peel and the Durham region are right now organizing to develop coordinated access. So I think it will be coming to your local community soon. One of the things that is also important is family resources. So a lot of family members are not sure where to turn. And as Dr. Fung had talked about, a lot of family members are the way in to engage people in services. So they might not be willing to engage on their own, but a family member might be able to help them to engage or to accompany them and provide support while they're engaging in services. Sometimes that's not the case. Sometimes the unwell individual is still not willing to engage in services, but the family members who are the caregivers need support too. And so here on the screen we have some information where family members can actually get support. And it's specifically designed for family members by family members, which is really important because I think a lot of family members want to know that they're understood. And so how best to be understood but by another family member who has experienced similar situations. The other thing is, sometimes you're not sure what kind of supports your clients may need. Maybe it's not clear that it's a mental health issue, and so you may not know that for sure. So there are other hubs that work with other kinds of services that may be helpful for you as well. So there's something to think about is developmental services, or Carrie's Place is a provider who deals with individuals who have Asperger's syndrome. Seniors has a whole bunch of different services outside of the mental health network that you might also be able to access if your clients are from seniors categories. And so there is a hub called Community Navigation and Access Program, CNAP, which has a whole host of other services that they can access through their hub. And they're quite easy to access. It's just a phone call. They don't actually have a large application form. You can call in, tell them what the issues are, and they can take over from there. In London, I know that there's a number of attendees here from London, and I believe from Kitchener. So we have listed some organizations here that may be a good way for you to start to find support for your clients. And so connecting with and making relationships with some of these organizations is probably quite a useful thing for you to do. So getting these organizations or getting to know people who work at these organizations so that then when you have a client who comes to your office who you think might have mental health issues, you could always connect with these individuals and try to get some ideas from them about how you can engage them in services. So here's some information from London, and here's also information for Windsor. And you guys will have access to these slides after the fact. One of the things that I should probably mention about Access One is that we do a pretty in-depth assessment, and we can do that either over the phone or in person, depending on how the individual is wanting to do the assessment. And that's where you guys can come in real handy by helping the individual either be present with them on the phone or potentially be present at the intake assessment. We can come out to the community to do the assessment, so we could even meet at your office, which could be more easy for you in order to support the individual to make that link. Often, if someone is feeling comfortable with you, they might not feel as comfortable to tell their story to someone new. And so having you present could be quite helpful to making that successful link to another service provider. So one of the things that can be a challenge for our assessments is that we do ask a lot of personal questions. We're asking questions so that we can gain a really good understanding of what the services are that the person might need, what their goals are, and then trying to make the match between all of those service providers that we have access to. So we want to make a good match between what the person's circumstances are and the organization that would be providing the service. And so we do ask for quite a bit of information. And sometimes that can be difficult, especially for people of different cultural communities where they may not be accustomed to speaking on different topics. And so sometimes your presence can help smooth that over, or can help educate us so that we know that those are questions that might be difficult for the person to answer, or might be areas that they may not want to talk about. We also have access to interpretation. So although your services can be helpful for the Access Hub too, and your participation can be helpful, we also do have access to languages that can be quite, that can really be helpful in terms of getting to make the person feel comfortable. So we can be able to ask the questions within their own languages, which can be helpful. So I think that's probably it for me. I guess one of the things that I would want to reiterate is that, you know, the services from the Access Hub, their case management and a sort of community treatment, but that there's lots of other services that your clients could also access. So one of the things could be looking at the local hospitals. Some of the local hospitals have day programs that could be accessible to your clients, or they might have outpatient programs that could be at least a foot in the door to getting someone into services. There's also a lot of mainstream programs that people would like to go to. I find a lot of individuals are hesitant to connect with mental health services, and part of that could be, as Dr. Fung talked about, some stigma and some shame, and not wanting to admit that they have a mental health issue. And so one of the things that you might want to consider in making referrals is looking at some of those mainstream organizations that could provide some activity or some service or some support for individuals, but isn't specifically geared towards mental health. That could be a way of getting, again, someone in the door to be willing to accept some services and then later be able to access the more specialized mental health services. So I think that that's it for me. I think what I'll do now is thank you for your time, and I think I'm going to pass it back over to Stephanie, and then we'll start to take some questions.
Okay. Hello, everyone. Yeah, I just wanted to say a brief thank you to our two wonderful presenters. I hope everyone learned a lot. And yeah, I guess now it's time for question period. So what we're going to do is Dr. Fung and Alison are both going to try to share our little video here and answer your questions to the best of your abilities. So yeah, please remember when writing in the questions to write down who you're addressing it to, whether it be to Dr. Fung or to Alison. And yeah, like I said, if we can't get to every single question, we are going to be saving them. So the ones that we are not able to get to today, we will try to email you the answer. Okay. Thank you.
Okay. Do you want to come into the screen so we can share? You can still come closer to me.
There we go. There. We both fit now.
You both fit. Good. Okay. Okay. We'll just see if there's... so right now is the time for questions. I hope that our talks have been stimulating somewhat for you, and so that feel free to ask any kind of questions, because I think this is a challenging area. Earlier, I put down that one of the steps is acceptance, and I don't mean only acceptance of, well, this client is so difficult, we'll have to just accept that he's going to be difficult. But it's also accepting our limitations within ourselves, and even our frustrations, right? Because we all have frustrations because we only want to help so much. So when we get frustration, we also need to accept that that's actually part of our concern and caring. Now, I don't think that there are too many questions at this point, so there's lots of room for you to get your question in. There's one question, Mulagita, addressed to me, but I think you can also answer too. When following up with the consultant on a referral I've made, what if the consultant is not disclosing? Can you give us some tips of effectively following up with the consultant? I think that's a very good comment, because I put down in my presentation that one of the steps is we need to follow up. Sometimes we don't know what had gone on. Sometimes the clients may not have any clue about what's to happen next. They've gone for an intake assessment at some agency for the first time, or they've seen a psychiatrist, or they've seen a counselor. The person may not understand what's next. And so sometimes having a connection with the consultant is good. Now, what if the consultant is refusing to disclose? Now, there are, of course, many reasons why consultants may not naturally disclose, because chiefly for confidentiality reasons. Now, there are a couple of ways to look at this issue. Under the current privacy concerns, there's so-called the circle of care, that if we are in the circle of care, then we are supposed to be able to pass information to each other so that we can precisely close the loophole to ensure clients don't fall through the cracks. So we can have this discussion with the provider that we are in a circle of care. Now, of course, the best way sometimes to ensure that does happen, though, is that the client is in agreement for sharing this information very explicitly, i.e., if the client can sign some kind of a form, or the client can say to the consultant, that's why you have this briefing sometimes beforehand, is it okay if my worker so-and-so who refer me at least get to know what the plans are, right? So in other words, sometimes if you talk to the client even before the consultation, you can say, it's not like I want to know everything you talk to the consultant about, but at least it'll help me to understand what the next step is, how to facilitate that. And sometimes clients would be, even if they feel like they want their privacy, that they are at least, at the very minimum, okay to that part, right? And so then they would be able to tell the consultant, either before, during, or after, that yes, it's okay for my worker to know what the next step is so that he or she can facilitate the next step. So I think that those are two. So one is the circle of care. The other is getting very explicit permission from the person, the client, if not for everything, because you may not need the whole thing. You may just need at least what the next step is. Yeah. So targeted information. And I think for most cases, most clients would be very willing to say, yeah, don't get into all the stuff I've talked about, but at least know what the next step is.
Yeah, I would agree. I think especially for a lot of you guys who work in settlement agencies, you probably need expressed consent, so a consent form to say, I give permission for X, Y to speak to A, B. Because in terms of the privacy legislation, it's organizations that are considered health information custodians. And I'm not sure if all settlement agencies would be considered health information custodians. So the best thing to do is to get that signed consent, and then you shouldn't have any trouble with another organization connecting with you and following up and providing you with the information you're asking for.
And a lot of agencies have their own little form that you can get the client to sign ahead of time. So I think all of that would be helpful. Okay, we have another question. This is for Alison.
For me, yay. So the question is, I would like to know about the language support for access. So this is from Jacqueline. For example, how many languages are available? Do you use language line service, or do your point of access staff speak many languages? So we do both. We have some languages within our staff group. So we have Mandarin, Cantonese, Vietnamese, French, Hungarian, and some Spanish. So sometimes if applicants require having a conversation within those languages, we can do that right from our office. But we also have interpretation services through MCIS, which has more than 250 languages, and we can get access to them on the phone fairly quickly. Of course, obviously, if we have an applicant who comes in and wants to make an appointment with us, the best thing to do would be for us to have a little bit of notice so that we can arrange for an in-person interpreter. But if we don't have that luxury, we can access the language line and get interpretation pretty quickly. So at this point, I would say any language you can throw at us, we could probably get an interpreter for. So thanks for the question.
Okay, so I don't think that there are any other questions that's popped up so far. So maybe I'm just going to ask, we've got a handwritten question. How do people get referral to a psychiatrist? Who to ask? Do I need a referral? How long is the wait? Okay, so this is a written question for getting a referral to a psychiatrist. So psychiatrist has a specialty in medicine. So most of the time, it needs a doctor's referral. So the usual route to getting an appointment with a psychiatrist is through a family doctor. So family doctor or primary care is the usual, or nurse practitioner is the usual point of first access, where the primary care physician or nurse practitioner would fill a referral form and refer to a specialist or psychiatrist. There are some exceptions to the case, of course. There are individual psychiatrists who may have different kinds of practice, so they may have other ways. And for example, if a psychiatrist is working with early psychosis programs, including my program here, early intervention psychosis to facilitate early access, sometimes there's no mandate for actual physician referral. So even a family member can self-refer to a lot of different early psychosis programs. Just to give one example, where there are situations where in a particular circumstance, people may get access to a psychiatrist without a referral system. How long is the wait? I think that's quite variable, depending on the exact psychiatrist. And for, of course, language-specific psychiatrists, the wait may be also longer. So I think there are different wait lists. Maybe at this point, I would also say some people may ask what the difference is between psychiatrists and psychologists. I don't know whether this is a general knowledge, but certainly they are quite different. They have quite different roles to play, even though they sound quite similar, especially to the public. The public usually have no idea what the difference is between psychiatrists and psychologists. So just kind of brief, and I get that question asked all the time, every mental health talk to the public, because usually a public in the audience is confused. Even in the Chinese translation, they are sometimes mistranslated one for the other, for example. So a psychiatrist is basically a physician who has finished medical school and had gone on to have residence training in psychiatry. So in Canada, that means 4 years of medical school and then 5 years of training in psychiatry. Psychologists come through a different route. They do not go through medical school, but through university, they study psychology. And to be qualified psychologists, basically they are PhD level in psychology, and they would call themselves a psychologist. And here, there are many kinds of psychologists. There are psychologists who specialize in psychometric testing, that is like giving IQ testing or personality testing or inventory to see where the mental state is at. So there are a variety of psychologists developed psychometric, we call psychometric testing, that is what certain kinds of psychologists would do, and sometimes they're even called psychometrists. There are clinical psychologists who would see people with mental health issues and provide direct service because they have not gone through medical training. They would be providing counseling and psychotherapy. A lot of them are really excellent psychotherapists, and so they, through other means, help persons with psychological and mental health issues. A psychiatrist in Ontario is billed under OHIP, so it's covered, so that's often another kind of consideration because so it's government-funded healthcare provision, psychiatrists. Psychologists are non-OHIP funded. A lot of insurance companies cover it, so a lot of people are able to get access to psychologists, at least for an X number of sessions through their insurance. So it's helpful to ask the client whether the client has kind of insurance. Sometimes if you have clients who are in a motor vehicle accident, even the insurance compensation, they allow certain number of sessions with psychologists, and they are able to intervene as well. So that's just something about, so there are also two different systems of getting help and getting referral.
Another thing, a lot of social workers are also now able to bill through some insurance companies, and so sometimes your clients can get access to social work as well if they're working and have benefits.
Good point.
So we have another question for me. How long is the wait list for case management? And then the secondary question is, will Access One staff help us fill out the forms? So those are both very good questions. So wait list is a problem. We have more demand than we have resources, and so depending on where you live in which community, the wait list can vary. In Toronto, there's a wait list anywhere between 6 and 8 months. Although we're keeping the wait list for all of Toronto, we have kind of discrete wait lists based on location in the city because our service providers have specific geographic areas that they work in. So right now, I believe Scarborough and North York have fairly long lists, wait lists, and so it's about 8 months, whereas for other parts of the city, it's about 6 months. Now, for assertive community treatment, that's a bit different, though. That usually is up to about a year waiting for assertive community treatment. In terms of will our staff help us fill out the forms, we do have peer support workers on staff, and an applicant can even drop into the office or can make a phone call and speak to our peer support workers who can help them fill out the forms. So yes, we couldn't do that with every applicant, or else we'd be too busy filling out forms instead of doing assessments, but we certainly have the ability to help some people with filling out the application forms. And we are looking at translating some of the application forms into some of our languages that are really popular languages for us. And so we're looking at Mandarin, Cantonese, Vietnamese, and Korean right now to translate our forms so that individuals may be able to then fill out the forms themselves in their own language. So those are things that are in the works for the next few months. We have another question from Jacqueline. My query is difficult to phrase, but I will try. It is appropriate to refer a newcomer experiencing new arrival depression to Access, or are referrals more appropriate for individuals with symptoms of or a diagnosis of a psychiatric illness? So I would say that if people are experiencing stress and depression related to being a newcomer to Canada, I would still potentially make a referral to Access One. Some of our organizations need definitive mental health diagnoses, and some of them do not. And so if they don't have a specific diagnosis, it might limit the organizations that we could send an applicant to, but that doesn't mean that we can't find something for them. So if one of the things we look at when we're assessing is we look at diagnosis, but we also look at disability or the level of severity of their of what they're struggling with. And so diagnosis, although somewhat important, is not the be-all and end-all. So we can certainly assess that individual and look at what it is that they're needing and which of our service providers could help with those areas. So I would say that that's not an exclusionary criteria. So I hope I've answered your question, Jacqueline.
I think that's also a very important point, actually, because new arrival depression is a tricky one, I think, because sometimes we expect that, for new arrivals, of course they are depressed. But that may or may not be the case where they have the so-called new arrival depression. In other words, the person may have very significant depression that we don't know about. So because it's kind of a common, I guess you can err on both ways, right? So there are people who go through life stress like immigration, refugee, relocation, even job loss or even marital, problems. On the one hand, you can argue, yeah, it's quite common for people to be sad. People should be sad. People are grieving. People are unhappy. So sometimes because of that, we can underdiagnose depression. That is, people who are actually suffering, but either they themselves are not admitting, and we also would underdiagnose. We don't know that the person is actually suffering. So sometimes we have that problem. Of course, there's also controversy in the field that sometimes we're overdiagnosing. We're calling everyone depression when everyone is just sad because, I don't know, the last Olympic ring didn't light up or something. So I mean, you can go either way, either like over-calling things or under-calling things. So I think it's a real issue, and I think people are concerned either way, that we are over-calling things or under-calling things. I think the issue is I think as any kind of service providers have a hint of something is wrong, I think that we should at least encourage the person to speak up more. Because if you can imagine, people are generally speaking reluctant to talk about how they feel and stuff. So if you are able to detect that they are indeed feeling kind of depressed, so sometimes that's just the tip of the iceberg of what they're willing to disclose. So I would say that sometimes maybe we err on the side of just checking out, making sure that things are okay. And if there's any uncertainty, call Fook or advise the person to talk with a social worker or a family doctor. And so I would say, if in doubt, investigate more rather than investigate less.
Mm-hmm. And one of the things that I think is important to ask is around substance use as well. I think a lot of people use substances as a form of coping, and so that can also end up leading you to ask a bunch of questions that can get more information for you about what's really going on. And we have a lot of individual applicants who come to our Access Hubs who are their first thing that they're identifying as a problem is substance use. And then as we dive further, we learn that there's a lot of other issues going on too. So that's something that we didn't really focus on in the presentation, but it's something to think about. And you might see that more in your clients if they are really struggling with settlement issues and not knowing how to cope. So.
Great.
We have another question here. Since the wait is so long for services, what do we do with clients while they wait? So that's a challenging one sometimes because the wait is so long. At Access One, as I talked briefly about, we do have access to short-term case management, and we also have the peer support workers. And a lot of the coordinated access hubs that are starting to be developed are embedding those two types of services within the hub. So sometimes if there's a critical issue going on that can't wait the 6 or 8 months until someone can get long-term services, we might plug in short-term case management to help deal with that for a short period of time. What's an interesting statistic that we have at our Access Hub is that 45% of individuals who get the short-term case management support don't actually go on to stay on the long-term wait list. So their situation has been resolved to a point where they don't think that they actually need the long-term support anymore. So getting in and doing, 60 days worth of service and helping them sort out that issue can sometimes really be effective. It helps with our long-term wait list at the back end, but it also helps the individual resolve the issue quickly so that it doesn't become a really tragic issue or something that's much bigger than it needed to be. The other one is the peer support. So we have people who work in our team who have lived experience with mental health issues. So they would identify themselves as consumer survivors of the mental health system, and they can provide informal counseling. They have a lot of information about the different complementary services that individuals could access while on the wait list. And what we do is we check in with applicants every 3 months. So if they're on the wait list for 3 months or more, they absolutely get a call from a peer support worker to check in and see how things are going. But the applicants also get the peer support workers' phone numbers right when they're deemed to be eligible and put on our wait list. So they can call the peer support workers anytime for informal support or information about different resources. And it's at that point, at sometimes, when a peer support worker is talking with the applicants, that they might identify that there's something bigger going on now, or maybe the situation has changed from the original application date and something's gotten worse. And so they might highlight for our service navigators that something's happening. And so we might then reassess and put in short-term supports at a sort of later date because of the information that the peer support worker has given us. So there's the two things that we do for individuals on our wait list.
So again, we encourage people to type in their questions. I don't think there's another question I see, at least at the moment. Just want to acknowledge that Abrami had typed self-esteem, confidence, abilities. I believe that this is actually in response to my question about what people think are why people don't get help, and maybe they don't have self-esteem, maybe don't have confidence, or maybe don't have the ability to access service. So those are good thoughts. Self-esteem and confidence are issues, and they're quite related. And sometimes people, it has to do with that self kind of image about what it is to get help. It can undermine their self-esteem to admit that they have and that they need help, external help. So I agree with that. Don't worry. You don't need to apologize. You could have actually. That's good. If Abraham is saying that maybe you should have written on a piece of paper. No, actually typing it in so that we can share with the group is also very helpful.
So we have another question from Jacqueline. This is great, Jacqueline. Thank you for all of your questions. Is immigration status a barrier to accessing mental health services? Most of the time, it is not. Again, there are a couple of organizations within our network that do either specifically work with people who have particular status in Canada or not. So again, our staff are aware of which organizations that someone would be eligible for or not eligible for, depending on their immigration status. So I would say it's not a barrier. We will assess and try to get them to the right supports that are right for that person. Again, it's not as much of an issue for us. I think sometimes it can be for some of the OHIP programs because someone needs an OHIP number in order to pay for the services, but a lot of our services, we don't necessarily ask for an OHIP number, and so it can be anybody.
Does that include refugee status?
Yep.
Yeah.
Yeah.
Mm-hmm. Okay. So another question here. Can you tell us more about the explanatory model of illness in cultural context and how cultural explanations of mental illness can prevent people from seeking help, and how do we address this? That's a very good question. So the term explanatory model of illness, as I've put down, it does come from cultural psychiatry, medical anthropology framework of recognizing that each culture has within their own culture how to view illness. So there's a whole set of questions that we usually encourage people to ask, including what do you think the problem is? What would you call this in your own culture? In your own culture, how would you handle this kind of problem? Because, for example, they may not say depression. They may say If I have a problem like this, it must be because I don't sleep well, or it must be because my yin and yang and my qi is imbalanced, or maybe I have some problems with my organ liver. So different cultures may have entirely different explanations. So getting to know how they understand it, what they think had caused it, because they may give totally different explanations from what you or I might think. What can make it better, and what can make it worse? Who are the kind of people who usually can help you with this kind of issue, right? So by asking these kinds of questions, you are trying to understand from their point of view how they would usually handle this problem. Now, quite often then, we would find out that in different cultures, they have a completely different way of understanding this. And if you ask, well, what about getting mental health services? A lot of them from their own countries, they may say it's only reserved for people who are violent or people who need to be locked up or things like that. That's obviously not the mental health system here. So so the usual steps is inquire about what they believe, and then we can actually go back and have some discussion about how the system works here, what we believe in here, and then it's actually kind of a negotiation about what makes sense, right? And acknowledging this makes sense. So sometimes we use the mnemonic learn, right? Listening to the other person, right? Understanding the other person's explanatory model, acknowledging and explaining your own model of understanding. So first you listen to their model, then you explain your own model, and then you acknowledge that there's differences, right? And then you make a recommendation, and then you negotiate. So we use that mnemonic learn to say we have to go step by step. We first listen before we then explain, and then we acknowledge there's a difference, and not just say, well, this is what you need to do. We acknowledge there's a difference here, and then you recommend based on your understanding, but then you negotiate what is feasible, what is reasonable, and what is doable. So that kind of process would be a step-by-step process to address these differences in explanatory model of illness.
I think that just from the Access Hub's perspective too, we see cultural differences in terms of how people actually approach our services and how they try to access supports. And so we again try to work from whatever's going to help with having the individual access services. So sometimes it's mom or dad who are calling us up and asking for support for their loved one rather than the actual loved one. And so from our cultural context of the Western world, we want consent from the actual applicant to say, do you want this service, and are you willing to engage with us? But at the same time, we'll still work with the family to try to be supportive of that cultural context to help someone to get the services that they need. So we see that in terms of access and how people access services as well. So we have another question here. What can workers do to reduce clients' feelings of stigma and shame? That's a big one. That can be quite challenging, actually, at times. Do you want to take a stab at that, or do you want me to?
Either way.
Okay. Well, I could start, and then you could help me?
Sure.
Okay. One of the things that I'd be doing is asking, getting more of an understanding of how that individual or how their family or how their culture views illness and views mental illness specifically, and what are the concerns that individual has in relation to speaking about what they're experiencing. Sometimes I wouldn't necessarily phrase it as mental illness, but looking more at what are they experiencing and how are they perceiving what's going on for them. So if I get a sense that there's a lot of stigma and shame, I might just not even use the words mental illness and might talk more experientially.
So I think those are really excellent things. Using a terminology that a client understands. Now, stigma and shame, of course, is a big issue. And I guess we can look at it from multiple perspectives. How do we work with an individual client who's struggling with this issue? And also, how do we address it at large, because as we kind of imply, stigma about mental illness is not just with one individual, but kind of societal. So it's all of it, right? So we can look at it, and I can look at this question as kind of almost asking like two different things, and maybe I'll try to kind of address a little bit of both. I think maybe we'll start from the societal, because that's where stigma begins. It's a huge issue facing the mental health field. The Canadian Psychiatric Association has like a position paper on it, like how stigma is one of the most important challenges facing mental health. The Mental Health Commission of Canada has identified it as one of the most important issues that we need to address. So mental health stigma is very real. And if you look at the society, if you look at news stories, anytime you hear something about mental health in the news, 99% of the time it's when someone is gone out of control and there's some violence. And so in the public's mind, quite often there is this sense that mental health and illness is associated with violence. So addressing it at a society level ultimately is very important to counter a lot of these messages. Now, there are lots of community-wide or many kinds of interventions that's been looked at. And from what you would think, education is the key to go in terms of educating individuals, educating societies and communities about mental illness. Now, what has been found in scientific studies is that education is a pretty poor way of actually changing stigma, in that even though we do a lot of talks and we do hope to change stigma, and we still do them, in fact, it's very hard to shift stigma with education, direct education, and some studies have shown that. Now, another type is a protest. This is in this research literature. In other words, when you hear and when you see there are discriminatory things happening, we stand up and protest. Just like you hear about gay rights in Olympics, people standing up for discrimination about mental health. So if you hear and see this discriminatory stories in the newspaper that's reported, you speak out against it. That kind of fighting stigma has also been studied in the literature. It's also been shown to be quite miserable in changing public opinion about stigma. In fact, people tend to react the opposite to it. I don't know if the same is happening with the gay rights issue, but certainly sometimes people see this protesting, saying that, we want to champion the mental health issues. Sometimes they have the opposite effect of almost reinforcing that, it's something dangerous, something we should not talk about. So that's why it's been found in the literature that our usual common sense, that we'll protest, we'll make a stand, or we educate, that's going to be effective in changing stigma. In reality, it doesn't work all that well. It doesn't mean that we should stop doing these things. We're still engaging doing all these things, and Fung is engaging in doing all these things. But it's not a very efficient way from studies. Otherwise, there will be no stigma already. The thing is to realize stigma is really, really hard to shift. Now, what has been shown in studies to be slightly better is actually what we call contact-based education. Contact-based education meaning having peers and people with lived experience disclose and talk about that openly. And that's been shown in studies time and time again to be the single most powerful intervention. So in other words, you can have an expert talk about mental illness. You can have Fook talk about mental illness, a worker, but that's not as powerful as a person with lived experience talk about their own mental health journey. And that's what's been shown in studies, various studies of different kinds all around the world, is that the single most impact is actually to hear from people with lived experience talk about their issue, and that can most effectively combat stigma. So not that the other things don't work, and we need to stop doing psychoeducation, we need to stop protesting injustice. It's just that it's not going to be as effective as we engage people who live experience in that way. So what Alison talked about, having the peer support worker support the people who are struggling to get help, it's very powerful.
Yeah.
So,
and connecting your clients to your local consumer survivor networks is really, I think, a helpful step too, because a lot of the communities within Ontario now have consumer survivor support networks or organizations that are run completely by consumer survivors. And so individuals can get support through those organizations as well.
and so for workers to deal with an individual client's feelings, we can, again, think about much the same approach. Education is going to be a component of it. So education in terms of bringing knowledge about what mental health illness is and isn't, because there are a lot of sometimes even myths about it, that it has to do with something that's contagious, or maybe it's something to do with my failure. So a lot of those underlying thoughts about it, when you're working one-to-one on a client, is so important to elicit. And the feelings of shame and stigma, we call it shame. This feeling of shame means to hide. So in other words, it's an emotion that makes people want to hide. And by opening a dialogue about that, we are actually, by talking about it, we're shedding light into something that is hidden. So by opening up a door and acknowledging an emotion, acknowledging even shame itself, that it must be difficult to talk about, even think about that this is possibly a mental health issue. By opening this door to talk about feelings, sometimes can be the very helpful thing the person needs. So going with the feelings, going with what the person is thinking, bringing in some education, and where possible, bringing in life experience, other people's struggle, other people's experience. All of this can help to address, I think, some of the stigma and shame. Now, keeping in mind the cultural issues of what I mentioned earlier about collectivistic culture, sometimes the shame is a family thing. And so understanding the cultural nuance, perception, what shame and stigma of mental illness mean to you, and also what it may mean to the family. Because sometimes it may mean if the person is willing to admit they have mental illness, that means they cannot be married, right? So sometimes there are other implications in their culture. So understanding the whole cultural context of that can also be an important piece. Now, I would also say what has been shown in research is that, who do you think would have the most stigma about mental illness? A lot of studies actually found are healthcare providers or service providers. And that might be surprising, but that's what research has shown. And even medical doctors who are not psychiatrists. And so what we found then, in fact, are service providers, that's ourselves, we may have stigma about mental illness. And I think all of us have certain kinds of stigma about some things out there. As in this kind of politically correct society, I think sometimes it's not okay to admit that we have prejudice and stigma. But in fact, research shows everyone has stigma. It's almost impossible, unless you're inhuman, to not have stigma, because stigma comes from our ability to judge. And without judgment, we'll all cross the street on a red light and get hit, and we'll all be extinct. So by virtue that we're all alive and breathing means we have judgment. And those judgment entails we have discrimination. So it is actually by accepting and knowing that we have stigma within ourselves, again, that would be, I think, an important first step. So to look at this, we sometimes look at what's called the social distance kind of inventory. Like if you ask yourself whether you have prejudice against mental health clients, you may not have any. Then we can think about other things like, would it be okay for your neighbor to have schizophrenia? Would that be okay? Would you invite that person to your home for coffee or tea? Would that be okay? Would you make friends with a person who has mental illness? Would that be okay? Would you marry someone? Would you date someone? Would you let your daughter and your sister date someone with a severe mental illness? So as you answer these questions internally, you can see if there's any kind of resistance or negative thoughts about it. And if you do, you're probably in the normal vast majority category of having judgments, having different kinds of thoughts, judgmental thoughts, that is not abnormal but normal. It's how do we work with having these thoughts, and how do we, even though we have these thoughts, continue to do our work and, in fact, help everyone to decrease this kind of stigma. So, in fact, I'm currently engaged in a study, multi-site study, to engage people who would want to get trained to become champions against mental health stigma. Fook, as a matter of fact, is one of the partner community agency. So one of the sites is in Toronto, another site is in Vancouver, and a site is in Calgary and Edmonton. So if you actually, anybody listening here, you're in the field and you have some interest in joining the cause of fighting against mental health stigma, you can text or email or let Fook know, because Fook is also one of the partners. So if you're in this conference, you're now impassioned about the need to decrease stigma, and you want to know more about it, you want to hear more about this research project that we're doing, and Fook being one of the partners. So contact us, and we'll hook you and we'll engage you in this. So I think looking at our time, we're going to soon run out of internet time. At this stage, I would maybe pass on the floor time to Stephanie.
Okay. Okay. Oh, thank you, Margarita. What a wonderful compliment that you've given our panelists there. Yeah, I would have to agree with you that I learned a lot today also. So I really enjoyed being a part of this as well. So I just want to thank all of our participants for joining us. And I'd like to remind you to please fill out the quick evaluation survey. It should pop up in your screen as soon as you close the screen for the webinar. So it shouldn't be an issue. Yeah, and I guess that's it. If you guys have any more comments or thoughts about this, feel free to email me or Maria. You should all have our emails. And we hope to see many of you at our next webinar. And we also hope that we'll continue to be able to offer more and more of these. We think that this first one's been a great success. Thank you so much, Alison. Thank you so much, Dr. Fung. This has been a great afternoon, and have a good day, everyone. Goodbye.